доказательства. Можно спасибо. Когда вы у себя, я не знаю, где вы. Можете не делать, если что, дальше. Все, я понял. Okay. Okay. Dear students, it is 10 to 2. I am Dr. Lifshitz, Associate Professor of the Chair of Obstetrics, Gynecology and Perinatalology #1, Medical Academy named after Georgievsky. And we are about to start a lecture devoted to family planning, which is connected to obstetrics and gynecology problems. I hope that all maximum of students will be online, and in a couple of minutes I'm starting lecturing. Please denote who is present. I hope you know how to do it, and be ready to listen, and we'll discuss these topical questions. Well, I hope we can start. And I have nothing to disclose for this topic. I have no conflicts of interest in this topic. Family planning, guys, allows people to attain their desired number of children, to fulfill their families, and to determine the number of childs in families. And of course, it can be regulated and with contraceptive methods, and also with the treatment of subfertility or infertility. If we look at the history of family planning, we can see that centuries ago, people tried to control their fertility. In Egypt, in the papyrus from 1550 before Christ, in the Kahun papyrus from 1850 before Christ, it was written that some birth control methods were used by people. They used honey, acacia leaves, and they inserted it into the vagina to block sperm. Well-known citric acid were believed to have some spermicidal properties, And women in ancient Jewish communities in ancient Israel, they used to soak sponges in lemon juice before inserting them vaginally, and so they use it as a simple method of contraception. Dong Quai, also known as Chinese Angelica, has long been known for its powerful effect on a woman's cycle. Ancient Greeks also used silphium for birth control methods. So, I hope that in your countries you may find some funny histories when what people did for contraception centuries or millenniums ago. Um, uh, do family planning methods or contraception give us some benefits? We need to think about it thoroughly because we have some opponents who say that we don't need to use family planning at all because we block human's fertility, we influence it, and it is against the rules of God. Different people have different opinions, but promotion of family planning and ensuring access to the contraceptive methods for women and couples are essential for well-being of women in many countries, in all countries globally, and support their health and health in the communities. Women's ability to choose uh, and to become pregnant has a direct impact on her health and well-being. Family planning allows spacing of pregnancies and can delay pregnancies in young women who are in increased risk of health problems and even death from early childbirth. Uh, it prevents unintended pregnancies, including those in older women who face increased risk related with pregnancy and deliverance. Family planning enables women who wish to limit the size of their families to do so, and evidence gives us that women who have more than 4 children at the family are in increased risk of maternal mortality. In increased risk, not direct impact, but in increased risk. And medicine uh, cope with risk factors by reducing rates of unintended pregnancies, unwanted pregnancies. Family planning also reduces the number of abortions and and especially unsafe abortions, which is quite common probably in some of your countries. For example, in Africa. Please think about it. It's very important. We want to reduce infant mortality, and family planning helps to do so because mothers have space before pregnancies, between pregnancies, sorry, and they may enhance their health after the delivery, after the labors, especially if this particular woman had some problems during deliveries. So it's very important. Don't forget about infections, for example, HIV and AIDS infections. Family planning. Some of the methods of the family planning of contraception reduce the risk of not only unwanted pregnancies, but also may protect against spreading of HIV. For example, male condoms and female condoms, not very wide common in in many countries, but they are available in some countries, provide dual protections against both unwanted pregnancies and against sexually transmitted disease. We want to reduce pregnancies among adolescents, among teenagers. Unfortunately, in Crimea, in the place we live, and you stay here, we do up to 20 abortions for girls who are younger than 17. So those 20 girls annually have problems with abortions, with their health, with their families. They terminate pregnancies. It is very bad situation for their health and their physical health and mental health. So we want to reduce those bad situation, and maybe I'm positive, I'm sure that in your fair countries, healthcare system also try to give the best for the population, for the people, like in our countries. So please think about it also. Family planning enables people to make choices about their sexuality and reproductive health, and fertility problems can be figured out by family planning system implementing. It's important that family planning is widely available and accessible through not only through the doctors, but also through the midwives and other trained health workers. That's why we work with our midwives and our nurses who can provide simple methods of consulting, of simple method of contraception to the adolescents, for the couples, for anyone who are interested in using it to prevent unwanted or unintended pregnancies. Some methods like permanent contraception, like sterilization, of course, those patients should be referred for their doctors, not for the midwives and for the nurses, as well as IUD, and we will talk about it later. Family planning usually studies medical issues like abortions, contraceptive use, contraceptive rates, ratio between abortions and deliveries, but also we can understand it may influence on demographics in your countries, in your regions. So population dynamics is dependent on the widespread of contraceptive methods. And also some reproductive health disease like infertility or recurrent abortions, spontaneous abortions, sexually transmitted disease prevention is very important for the family planning specialists. So, but we will talk today about contraception. And what is their modern methods of contraception? You see on the slide that the modern contraceptive methods should be highly effective. So patients or clients in some situations, our people, they may rely on it. So they may need to rely on contraception. So it should be highly effective. Also, those methods of contraception should be easy to use, because we don't want to recommend some methods which is very difficult to deal with. Nobody will use it, and we will have unwanted pregnancies, and we must remember that 50% of unwanted pregnancies, or they become abortion. They end up with abortions, and we don't want to see abortions in a clinical practice, really, no. Of course, in a real situation, of course, we have abortions in Crimea, in Ukraine, in Russia, in our countries, but and unfortunately, maybe in your countries, you still have some or quite high rate of abortions, termination of pregnancy. It's a very bad situation for the single person and for the healthcare system at all. So, modern methods of contraception, they need to be absent or may have low rate of adverse effects. We don't want to have patients who come with major adverse effects while using contraception, because contraception need to be designed for better living, better quality of life. So it should be safer for health. Unfortunately, we need to touch questions of money and some contraceptive methods, even all contraceptive methods, we need to pay for it. Healthcare system may pay for it, or patient may need to pay for it. So modern methods of contraceptives should be affordable. They must be affordable. And for patients who want to prevent pregnancies for some period of time, it should be reversible. On the other hand, some patients may need to use permanent methods, like I mentioned, sterilization. And in this situation, they should be irreversible. While talking about contraception in a medical system, we evaluate, we compare different methods of contraception by effectiveness or efficacy. So, efficacy of contraception is measured by so-called Pearl's index. Richard Pearl was the scientist who evaluated contraceptive methods with human fertility, and decades ago, in 1932, he published his work, Factors in Human Fertility, and now we compare different methods of contraception, their efficacy by Pearl Index. Pearl Index PI is a number of pregnancies divided by number of women to number of months multiplied to 1,200. So the lower PI, the higher efficacy. So less mistakes. The lower PI, less mistakes of contraceptive use. And vice versa. The higher Pearl Index is less efficacy of the particular method of contraception. But still, in the everyday practice, we when we consult patients, we usually speak in percentage of effectiveness. And in my presentation, you still will see some not Pearl's index, but more percentage of effectiveness. Well, contraception can be divided by several groups of methods. The first one is hormonal contraception. The second is intrauterine device as a contraceptive method. Surgical methods of contraception, permanent one. Those three methods are very effective. They have the highest number of effectiveness, so the lowest Pearl's index. When we speak about barrier methods of contraceptions and chemical methods like spermicides, they are okay, but they, of course, less effective than the first three groups. Natural methods, we'll speak about it later, may be effective but not as high as hormonal and intrauterine. Very specific, two specific groups like breastfeeding women, women who breastfeed, they may use natural postpartum contraception, and emergency methods of contraception for patients who didn't use planned methods like hormonal or intrauterine or barrier methods of contraception, so they may come to the office, doctor's office, and they need to be counseled what to do in emergency situations. So we will speak about those several groups today. Let's start from hormonal contraception. The name itself denotes that we use or recommend or prescribe hormones for preventing pregnancies in a particular woman. Hormones. What are the hormones? We prescribe female hormones, steroid hormones for contraception. We don't prescribe insulin or adrenaline or male hormones. We don't prescribe it for hormonal contraception for women. We prescribe female hormones, female steroid hormones like estrogens and progestins. Okay, so we and you need to remember estrogens and plus progestins, or only progestins, are hormones which are used in hormonal contraceptions, not other hormones. This is very important to remember when you will discuss it with your patients, with their families sometimes. We don't prescribe harmful, I would say, hormones which can be bad for the health. We prescribe only female hormones for female patients. Hormonal contraception may be oral, maybe vaginal, maybe transdermal. So we can prescribe hormones via different routes, like oral contraceptives, transvaginal, transdermal. Also, we prescribe by injections, and we call it injectables. Some companies, pharmaceutical companies, they invented implants which can be implanted in the female body, and some pharmaceutical companies, they produce intrauterine hormonal contraceptive systems. History of hormonal contraception started not far away. We are people who live in these decades, or of course you are much younger than we, but still it started less than one century ago. It started in 1930s, 1940s, and it's on the slide. And at the second part of the 20th century, biologists, physiologists, and gynecologists, they found that female steroid hormones may block ovulation for women. They accidentally found that mestranol, which is estrogen, with some progestin, synthetic progestin, may inhibit pituitary function and block ovulation through these mechanisms. Hormonal contraception contains two hormones, and they have specific method of action. It prevents oocytes to go from ovary, prevent ovulation, because it blocks follicle-stimulating hormone secretion. Okay? This is the primary mechanism. It blocks follicle stimulation hormone secretion in the pituitary gland. Then it thickens cervical mucus and blocks sperms from meeting outside by this method. And also it changes receptivity of the endometrium. So it prevents creation of the zygota by blocking ovulation, and also it prevents sperms to go through the female organism by blocking mucus. And even it's not proven by reliable studies, but even fertilization occurred, endometrium will not give the chance to implant the zygote. Adding progestogens to estrogen acts synergic to less hormones needed for ovulation control. Contains the first group of hormones are estrogens, and most of the pills available on the market, pharmaceutical market, contain ethinyl estradiol. It's a synthetic estrogen, which is usually not found in the natural male body. Few oral contraceptive products contain estradiol valerate or mestranol, which is metabolized by the liver to ethinyl estradiol. Progestins can be different in different pills. They divided by generations, like first generation, and so on. This old fashioned slide pictures us NOR, not available now, oral contraceptive pill, which was available in the Europe in the 60s. It contained very high level of ethinyl estradiol, 150 micrograms. And you see on this slide, which I took from Organon agencies, the level of estrogen lowered dramatically through the 30 years, from the 60s to the 90s. So 7 times less hormones level are now in the pills. You see, it's important to remember that we decreased number of the amount of estrogens in every pill, and because of this we decreased number of adverse effects, which is important for the female health. And estrogen doses were lowered after reports of increased risk of ischemic stroke, myocardial infarction, and pulmonary embolism, which was connected with the high dose of estrogens in the first contraceptive pills. If we speak about progestins or progestin agents, we see some groups, some generations, like I mentioned before, first, second, third, fourth, and we see that the first generation, the names of it like northiandrone or erinodiol or norgestrel or northiandrone, they are very good progestins with high progestational activity, but unfortunately those progestins, synthetic progesterone, have had some androgenic effects. You see, like norgestrel, very profound androgenic effect. What does it say? It says us that if we prescribe pills containing norgestrel or even northiandrone or noretidone acetate, patients may feel some androgenic adverse effects like deepening of voice, of her voice, hair growth, not immediately, but in several months maybe occur. Some problems with the skin, which is very important for ladies. And you see even the second generation progestational preparation like levonorgestrel, it has very high progestational activity, but unfortunately very high androgenic. So we now try to recommend, to counsel, to prescribe patients preparations which have more progestational activity and less androgenic effect. Like you see, desogestrel, which is high progestational activity and not very profound androgenic effect. And fourth generation progestin, like drospirenone, it virtually doesn't have androgenic effect at all. Unfortunately, it doesn't have very profound progestational activity. When we speak about progestins, because they're different in different preparations, in different pills, different pharmaceutical companies, unlike ethinyl estradiol, as I mentioned before, we can divide it by biochemical structure, and first are pregnenes, and then goes estranes and gonanes, and the last one is spironolactone equivalent, which it was the drospirenone, which I mentioned before on the previous slide. So those trig names usually medroxyprogesterone acetate, megestrol acetate, cyproterone acetate. It has very high anti-androgenic activity, by the way, and usually we prefer prescribe pills containing gonades, which are derivatives of 19-testosterone, and those preparations like the third generation desogestrel, Gestodane, are tolerated okay by our patients. The efficacy of all contraceptive methods, hormonal contraceptive, in a perfect use, ideal use by our patients, is about 99%. So the Pearl index is very low, up to well till 5 Pearl index. PI is like this. So 99% effective. Studies found that efficacy rate drops to approximately 95% by typical patient. Why it happens? It happens because we are humans, and humans make mistakes. So sometimes patients they may forget about taking pills, and even in some days in a row. And of course, it may lessen the efficacy of this method of contraception. Oral formulations differ with regard to the dose as well as combination of different progestins and estrogens. Currently, oral combination contraceptive pills contain ethinyl estradiol, as I mentioned before, in the dosage ranging from high dose preparation, 5 micrograms in every pill, to ultra low dose formulation containing only 20 micrograms. Combined oral contraceptives, they may be monophasic, so every pill is the same within the box. But on the other hand, some formulations may vary the dose of estrogen and progestins throughout their cycle. And so we call those pills biphasic, which says that it has two phases, two different combinations in one pill box, or maybe sometimes triphasic preparations. Example on the slide, you see this is the typical kit of their pills. It usually contains 21 pill in one box. So in the monophasic preparations, every pill contains the same amount of hormones. Usually those COC combined oral contraceptives, we usually write it as an acronym like COC, please remember it. COC stands for combined oral contraceptives. Usually we prescribe it 1 pill per day for 21 days. The first pill from the box usually starts on the first 7 days of their spontaneous menstrual cycle or withdrawal menstrual bleeding. So 7 days after the pill's finished, it should be pill-free interval. So patient may have rest of the pill for 7 days, and then if she wants to, you need to prescribe it for the next time, for the second cycle in 7 days interval. Brand new name is Clyra. It's a novel COC with dynamic doses. You see what happens during the one cycle of the pill. The first couple of pills in this brand name, Clyra, which is produced in Germany, and probably available in many countries across the globe. It contains, the first two pills contain only estradiol and estradiol valerate in the first days, 3 milligrams, and then it goes less. You see, throughout the cycle, 3 milligram, and then it finishes with 1 milligram only. But if we speak about progestins, we see that the Dianogest is a progestin. It's very potent progestin. It grows from 2 milligram to the 3 milligrams at the end of the pill. And those pills you see on the slide, they have different colors. And this new preparation we can also prescribe for our patients. Actually, transdermal contraceptives, they not very different from oral contraceptives like pills. We just changed the route of hormones to enter the human body, female body. The delivery of methods is different, but their names of the hormones are pretty much the same. Orta-Evra is a quite new preparation, contains well known for you already ethinyl estradiol as an estrogen in it, and norgestimate as a progestin, a combination of estrogen and progestin transdermal patch. It's available as a form of contraception in Russia, in the United States as well, and probably in many of your countries, like in Africa, India, for example. The mechanism of action of the patch is similar to the oral contraceptive pills, and it is released from the patch on every day, every minute. So it blocks ovulation, it blocks FSH secretion, which blocks ovulation. It changes the mucus of the cervix, and also changes the endometrium. So the principal mechanism for the transdermal contraceptive or transdermal hormonal contraceptives are the same. Blockage of FSH blocks ovulation. Number one mechanism. The Evra patch is may be applied on the buttocks, abdomen, upper outer arm, on the torso. Usually we recommend it to attach to the body on the first days of the menstrual cycle, and to change it weekly. After the 3 weeks of attaching, using it, you need to recommend 1 week in patch-free interval. So pretty much resembles all contraceptives. Also quite new approach for hormonal contraception is a contraceptive rings, vaginal contraceptive rings. So we prescribe hormones, female hormones for female patients transvaginally. Vaginal contraceptive ring, the brand name is NuvaRing, contains ethinyl estradiol and etonogestrel, which works by delivering ethinyl estradiol at the rate of 15 micrograms daily, and etonogestrel, which is metabolized to the third generation progestin, desogestrel, it's mistakes here, desogestrel, at the rate of 120 micrograms daily. Studies have shown that the Norrin is highly effective for preventing pregnancy and very well tolerated by our female patients. It looks like shown on the picture, on the photograph. You see patient holds the ring and may push it and may flex it, sorry. It may stay within the vagina for 21 days or 3 weeks, which is very similar to the oral contraceptive for 21 days and very similar to transdermal patch, which applied for the skin for 3 weeks weekly. So this is Norrin. The most common side effects of hormone contraceptives and Norrin particularly is irritation inside the vagina or on the cervix, sometimes headache, very common in hormonal contraceptive users, mood changes, including depressions, may be seen in all hormonal contraceptive users and Norrin as well, although the Norrin has very low level hormones inside. The rings may slip out and causing discomfort for some patients. Nausea, vomiting, vaginal discharge is not very common for Norrin, but may be seen. Weight gain, weight loss also, weight changes is can be noted by our patients. Vaginal discomfort is one specific common side effect for Norrin, and quite rare painful menstrual periods, abdominal pain, acne, and decreased sexual desire is noted by our patients. But still, although we see some adverse effects, contraceptions, hormonal contraceptives, combined oral contraceptives, they have some obvious non-contraceptive benefits for our patients, not only contraceptive, but non-contraceptive benefits. What are those benefits? All contraceptives shown to decrease risk of any pregnancy and ectopic pregnancy, so it's undoubtful plus. Dysmenorrhea, which is painful menstruation, painful periods, subside temporarily on time by using contraceptive pills. Anemia goes away because patients don't lose a lot of blood during periods. Usually periods become less in amount of bleeding. It was noted by oncologists in epidemiological studies that endometrial cancer, ovarian cancer, are less noted in contraceptive users. Ovarian cyst also seen less patients who used hormonal contraception at least 1 year. So, colorectal cancer, benign diseases of breast, pelvic inflammatory disease is seen less, and problems with osteoporosis is noted less in patients who used oral hormonal contraception and transdermal contraception and vaginal rings. Actually, very important issue that all contraceptives may improve cycle control for patients with disturbances of the cycle, and it's now very often can be seen in our patients, and also may help with some acne problems and with hirsutism problems, especially with patients with polycystic ovarian syndrome disease. Nonetheless, birth control pills, birth control patches, birth control rings, vaginal rings, are drugs. This medical preparation. And we need to remember some contraindications which are unfortunately available. And we need to remember and to know where to stop and when to stop. First, hypersensitivity of any of the hormones, known or unknown may be the contraindication. Known or suspected pregnancy. We don't need to prescribe contraception for patients who suspects, or you may suspect, or you may know that she's pregnant, because it may be harmful for the fetus. Smokers, heavy smokers especially, more than 15 cigarettes per day, and smokers who are older than 35 years old. You don't need to prescribe patients contraceptives. Cerebrovascular, coronary artery disease, thromboembolic disorders, pulmonary embolism, myocardial infarction, deep vein thrombosis, stroke, thrombophlebitis. Those conditions are contraindication for birth control pills, patches, or vaginal rings. If your patients have or may have some problems with breast cancer, this is the contraindication. Undiagnosed abnormal bleeding from the vagina, from the uterus, which may be suspects for endometrial cancer, for example, or ovarian cancer, is the absolute contraindication for hormonal contraception. Liver dysfunction, impairment, is a contraindication because any of their hormones are metabolized by liver, don't forget about. And there are some relative contraindications denoted on the slides, like diabetes, migraine, structural jaundice during the pregnancy, gallbladder disease. You need to discuss thoroughly with the patient's history, concomitant diseases, because we don't want to harm our patients. So this is all related for combined contraceptives. Let's talk about pills which contain only progestins, not estrogens, but only progestins, only synthetic progesterone. We call them mini pills because they don't have the second part of hormones, estrogens, and we call it mini pills. This is an alternative for combined oral contraception. So POPs is an alternative for COCs. And who are the candidates for POPs? Those patients are patients who may have some contraindications for estrogens. And good for women who would like to become pregnant in the near future, because progestins, only pills, they don't stop ovulation. It's not their cardinal mechanism of action. The cardinal mechanism of action of the progestin-only pills are thickening of cervical mucus, so blockage of the sperm just after the intercourse. So eggs, oocytes don't meet with the sperm. Also changes of endometrium, its receptivity. This is the second important mechanism of action of POPs. And only on the third place is ovulation disruption, and not in all patients and not in all months. POPs need to be taken as well as COCs, one pill a day on everyday basis, but the difference is without the break, without the interval for the rest, without the pills-free interval. So one pill a day without without interval. POPs, because they contain very low level of hormones, must be taken strictly at the same time each day. Not only daily, but strictly at the same time. In this, ideal users of POPs, effectiveness or efficacy would be up to 95-97%. So per limits maybe as low as 5 to 10. Please don't forget about. Well, intramuscular injections or injectables or injectable hormones for contraceptions, they could contain only progestins. And very well known across the globe, intramuscular injections for contraception is a Depo-Provera. Depo-Provera. It contains only 150 milligrams of medroxyprogesterone acetate. Medroxyprogesterone acetate is a synthetic progestin. Depo-Provera was the first non-oral contraception agent available in the United States, and it is injected only once in 3 months. It's injected in the deltoid and gluteal muscle once in 3 months. And while the mechanism of action by suppressing ovulation and change of the cervical mucus. Don't forget to the regimen of it once in 3 months only, because in oncology they use Depo-Provera 500 milligrams for the treatment of endometrial cancer, for example. It's a different preparation. It is not method of contraception. It's a method of treatment. Our drug is 150 milligram, is injected once in 3 months. The next Depo-Provera is a quite new one. Only 15 years ago it was available on the market in the United States. It's not available here in our country. It's a Depo-Sub-Q Provera, which contains 104 milligrams, and it's much easier to inject. It may be injected by the patient herself, and but it's not available now. But the mechanism is the same. Change of the mucus and change of endometrium, and in some patients it also blocks ovulation. The common adverse effects of this injectable progestins are irregular bleeding. We need to remember it. Also weight gain, delays in return of ovulation, possible reduction of the bone mineral density, especially in women who smoke. Ovulation most often recurs up to 6 to 12 months after their last injection, and duration of use does not seem to relate to the length of the recurrence of ovulation, but just their individual susceptibility to such preparation. Implants are not popular in our countries, but may be popular in your countries. It is synthetic progestin, which is can be implanted in the female's organism by an expert. Small flexible rods, capsules placed under the skin, usually of the upper arm, contains again only progestins, synthetic progesterone. It is very highly effective, 99.5% effective, so not much patients have typical misuse of it, mistakes, and can be used for 3-5 years, one package of it. After this, it need to be uh, removed surgically and reinserted, as shown on the slide. Common side effects of implants, progestin implants, are vaginal bleeding, changes, as I mentioned before, with injectables like Lipoprovir. Around 20% of women will have no bleeding at all, so they may complain of amenorrhea, no periods. It's not dangerous for the female organism, but patients may be anxious and may come to the office and ask you as a doctor what to do with such problem. Usually it doesn't have bad influence on the human body and female health, but still it may be some problems for some patients. Headaches, bloating, and tender breasts, changes of the skin, mood changes are common side effects of implants, progestin implants. I think we can break for 5 minutes, and I'll be back. Uh, just please hang on, and in 5 minutes I'll be back. We'll continue the presentation. Well, I want to continue. I hope you are here now. I look at the statistics who is with us. Uh, okay. Intrauterine devices. Um, Small contraceptive devices that are put into the uterus to prevent pregnancy uh, is considered to be a long-acting and reversible methods of contraception. Two types available are the copper IUD and the hormonal IUD, and both types are very effective methods of contraception with the very low Pearl index and can stay in place from 3 to 10 years, usually 5, 7 years in a row. Uh, Mechanism of action of intrauterine devices or IUDs are not well known by scientists, but it was hypothesized that the copper-containing IUD in the uterus um, decrease function of the sperm ability to reach the uterine cavity and fallopian tubes for fertilization does not occur. And as well by creating cellular changes to sperm to cause it non-viable. Ovulation has been shown to be prevented in some cycles with hormone releasing IUDs, but usually this method of action is connected with hormonal intrauterine device. It's shown on the picture. The IUD is in place with some threads protruding from the cervical walls to the vagina. This is the copper IUD, and to the left is the hormonal IUD. They are T-shaped intrauterine device. This is IUD view from below, or from the vagina through the speculum examination. You see the threads go from the external cervical walls. You see it here, and you see it here. Modern types of IUD are shown in the pictures. Some of them are T-shaped, some of them are horseshoe shaped, like here. Some of them are ring shaped. We need to remember that IUD should be inserted in our country by a doctor, special trained doctor, or in some countries, in some United States, for example, maybe inserted by a specially trained nurse or the midwife. Possibly in some African countries is the same. Surgical methods of contraception like female sterilization, tubal ligation, permanent contraception to block or to cut fallopian tubes. So all sides eggs are blocked from the meeting sperms. Male sterilization or vasectomy, permanent block or cut of the vas deferens that carries sperms from the testicles to the ejaculate. So it keeps sperms out of the ejaculated in the semen. It's a picture of the schema of the tubal ligation. You see it blocked and cut of the fallopian tubes. The function of the ovary is not impaired, the same. And these laparoscopical photographs of the fallopian rings. You see rings put on the fallopian tubes here, here. This is the uterus. This is the ovary, right ovary. This is the right fallopian tube, the left fallopian tube, the left ovary, uterosacral ligaments, pouch of the Douglas, and anteriorly is the wall of the bladder. And here you see laparoscopically put fallopian rings. Vasectomy is the male method of permanent contraception, is provided by urologist, by trained family planning expert. Usually it is done on outpatient basis. And of course we need to speak about barrier methods of contraceptions, like condoms, diaphragms, cervical caps and stems. Briefly, the history of the barrier methods of contraception. It started centuries ago when the syphilis epidemic was in Europe, and Gabriele Falloppio wrote the opus De Morbo Gallico about French disease and translated in English in 1564. And the British Committee noticed that decrease in deliveries due to condom use in the 17th century. During those centuries, physicians and society considered condom use as immoral. Until early 19th, only high society people used condoms because of the high price of it and absence of information for low social classes. In 1844, Goodyear invented vulcanization of the rubber process, and by production of male condoms started from this point. Sexual revolution in the middle of the 20th century and later HIV epidemic allowed to widen usage of condoms among people across the world. This is the picture of old-fashioned condoms made from the natural source, and those male condoms are very popular now across the globe. Male condoms are very highly effective, 95–99% effective maybe when it can correctly used. But if we see in a real situation, in a real life situation, the effectiveness of it drops significantly to 80–85%. Why it happens? Because we are humans and we can make mistakes. We need to teach our patients sometimes how to correctly use male condoms. And we don't want our patients come to us with unwanted pregnancy. If we recommend it, we counsel patients to use male condoms. So please pay attention to it. Also, we need to remember that male condoms may protect the partners of particular male men from sexually transmitted infections like chlamydia or gonorrhea, and HIV also. Please don't forget about it. Female condoms are not popular across the world, but you may find information on the CDC, Center for Disease Control in the United States, in the WHO website. So please don't forget that these methods of contraception for female are available. These condoms much more expensive comparing to male condoms. So you can read it directly on the website. Intercervical stems, like pins, may be inserted in the cervical canal to block canal from reaching sperms and go sperms up to the uterine cavity and fallopian tubes. It's not available now. And cervical caps were popular in the 70s, but now not popular as well as diaphragm, which are barrier methods and prevent again from getting sperms inside the uterine cavity to block fertilization of the oocyte by the sperms. And here you can see comparison between different methods of contraception, which I showed you before. You see the highest level of mistakes are related to diaphragm and spermicides. So if our patients want to use reliable method of contraception, we don't need to recommend non-reliable methods for such patients. For example, female students who come to our for consultation for family planning. She needs to study not to get pregnant usually. They need reliable methods of contraception, highly effective one. So please don't recommend such patients diaphragms, spermicides, and even condoms. Although it can be used by their partners, we need to prescribe more reliable methods like oral contraceptives. We see the percentage of mistakes is very low. Progestin pills, Depo-Provera, we mentioned before, IUDs 0.8, Norplant and tubal ligation. So other methods like hormonal contraception, oral, transdermal, vaginal are okay. One specific group of patients who also needs contraceptive counseling are patients who just gave birth. Very soon, in several weeks, those patients start to have sexual life, and they may be protected from unwanted pregnancies by physiological mechanism, which is lactational amenorrhea method, LAM method. Prevents breastfeeding itself, prevents the release of oocyte, and cause temporary, highly effective contraception, natural contraception for new mothers who breastfeed regularly. It requires excessive, exclusive, and full breastfeeding day and night. Interval between sucking of the breast should be less than 4 hours. 99% effective when it's commonly used. Temporary family planning method, of course, it's natural one. Some natural methods of contraception, like detecting basal body temperature, tracking those charts on every basis to control changes of the basal body temperature across the menstrual cycle, and patient and patient may know when her ovulation usually takes place. Of course, it's not very reliable method of contraception. So-called 2-day method, cervical mucus method, prevents pregnancy by avoiding unprotected intercourse during most fertile days, which is usually related to ovulation. Please remember that ovulation is the peak, it's the crucial part of the menstrual cycle, and patient is fertile during this day and plus minus a couple of days before ovulation. So women track their fertile periods, 96% effective, correct, but typically less effective, and difficult to use if a woman has a vaginal infection. It's quite a common problem for many patients across the world, and unprotected intercourse may be resumed after 2 consecutive dry days without secretions of the mucus. Symptothermal method prevents pregnancy by avoiding unprotected vaginal sex during most fertile days. Women need to track their fertile periods by observing changes like cervical mucus, body temperature, and the consistency of their cervix. Usually, it may soften just before ovulation. It may be very effective during the correct and consistent use, and typical use the same, but may be used in caution after the abortion around menarche and menopause, because those patients may have some problems with ovulation even if they are healthy. Calendar method or rhythm method, we speak with the couple. It's a natural method. It's not against some religious people. They believe prevents pregnancy by avoiding unprotected intercourse during the first and the last estimated fertile days by abstaining or using a condom. Women need to monitor the pattern of menstrual cycle over 6 months and will subtract 18 days from the shortest cycle length and subtract 11 from the longest cycle length. And we count menstrual cycles from the first menstrual cycle day. 91% patients, couples with correct and consistent use, and 75% of effectiveness in common use. May need to delay or use with caution when using drugs like anxiolytics, antidepressants, non-steroidal anti-inflammatory drugs, certain antibiotics, because those drugs may affect time of ovulation. And now we approach to the emergency contraception, which means that we can recommend it for patients, for people who didn't use planned method of contraception, and also may be important for our everyday clinical practice. Emergency contraception reduces the risk of pregnancy after unprotected intercourse. As soon as possible, usually need to be recommended 1-2 days after unprotected intercourse. And there are 4 types of the methods for emergency contraception. First, we can prescribe high doses of levonorgestrel, 1.5 milligram. The second option, we can prescribe COCs, usually for 100 microgram of ethinyl estradiol with 500 milligrams of levonorgestrel, usually prescribed twice. Emergency contraception may be using by IUD insertion, immediate IUD insertion after the unprotected intercourse within 2-3 days after it. And one brand new preparation, which is a ulipristal acetate, 30 milligrams, which is anti-hormone, anti-progestin, is prescribed for emergency contraception. We need to remember that patients may have some conditions with increased health risk as a result of unintended or unwanted pregnancy. Such is breast cancer, complicated valvular heart disease, long-term diabetes mellitus, endometrial ovarian cancer, epilepsy, hypertension disorder, chronic hypertension, HIV patients with stage 1-4, ischemic heart disease, malignant gestational prothromblastic disease, malignant liver tumors, schistosomosis with fibrosis of the liver. It's not available in our countries, but maybe in your countries. A severe decompensated cirrhosis of liver cirrhosis, sickle cell disease, strokes, systemic lupus erythematosus, thrombogenic mutations, and tuberculosis. Also very important, you need to remember that we live in a world when we code our diagnosis, and we need to code consultations for when patient come to the medical facility. And ICD-10, which is still in use across the world, it's the universal language, statistical language between different countries. You see on the slide, it's devoted also some information to the family planning issues like contraceptive management, Z30, and also Z31 for procreative management for patients who want to get pregnant although they cannot. You can find this information in the WHO website. WHO also published selected practice recommendation for contraceptive use, the third edition on 2016. It is in use. Please read it if you are interested in it. And my lecture is finished now. I think you now have some information regarding the contraception, the family planning, modern methods of contraception, and I wish you good reproductive health. And please read the necessary information in depth if you need some more information. Have a nice time. If you don't have questions, I will wait for a couple of minutes. If you don't have questions, you may be free, and have a nice weekend. Thank you.